Minnesota Rule 9544 for service providers licensed under Minnesota Statute 245A training.
Before we get started, a few navigation tips. You can find the full transcript of this video, including hyperlinks to the mentioned websites, by clicking the More link below this video. If you select the gear icon below, you can adjust the playback speed and select from available subtitle options.
Welcome to the State of Minnesota training on Minnesota Rule 9544, Positive Support Strategies and Restrictive Interventions. This training is intended for service providers licensed under Minnesota Statute 245A, except providers licensed under Minnesota Statute 245D who must follow additional guidelines, and child care providers who are exempted from these requirements under Minnesota Statute 245.8251, Subdivision 1, and Minnesota Statute 142B.63. This training will cover the intended purpose of the rule, who the rule applies to, background and other contextual information that might be helpful for successfully following the rule, an overview of requirements for functional behavior assessments, FBA, an introduction to positive support strategies, an introduction to person-centered planning, permitted procedures, prohibitions, requirements for emergency use of manual restraint, EUMR, resources for staff training requirements, requirements for reporting the use of restrictive interventions and incidents, quality assurance and program improvement requirements, an introduction to the External Program Review Committee, EPRC, and an overview of the variance process. After completing this training, service providers should review all definitions in Minnesota Rule 9544.0020 and training requirements for staff in Minnesota Rule 9544.0090, as those are not covered in this training. We also recommend reviewing the full Minnesota Rule 9544, as this training is more of a summary. To view the full 20-page rule as a single document, click the PDF icon at the top right of that page. Rule Purpose. The purpose of Minnesota Rule 9544, also known as the Positive Supports Rule, or PSR, is to enhance the quality of life for people receiving services. This rule requires service providers to use person-centered supports, promote community integration based on the person's preferences, focus on creating quality environments and lifestyles, develop positive support strategies through team collaboration, train the person receiving services to build skills and reach personal goals, develop support programs that value outcomes important to the person, their family, and the community, ensure people are free from humiliating and demeaning procedures, eliminate all uses of aversive or deprivation-based procedures, follow a consistent set of standards for responding to behavior, and train staff in positive behavioral supports, person-centered planning, and community integration. Applicability. As a 245A licensed service provider, you must follow Minnesota Rule 9544 when providing services to a person with a developmental disability or a related condition. A person with a developmental disability is defined as a person who has been diagnosed as having substantial limitations in present functioning, manifested as significantly sub-average intellectual functioning, existing concurrently with demonstrated deficits in adaptive behavior, and who manifests these conditions before the person's 22nd birthday. Significantly sub-average intellectual functioning means a full-scale IQ score of 70 or less based on an assessment that includes one or more individually administered standardized intelligence tests developed for the purpose of assessing intellectual functioning. Errors of measurement must be considered according to Minnesota Rule 9525.0016, Subpart 5. Deficits in adaptive behavior means a significant limitation in an individual's effectiveness in meeting the standards of maturation, learning, personal independence, and social responsibility expected for the individual's age level and cultural group, as determined by clinical assessment and generally standardized scales. A related condition means a person who has been diagnosed as having a severe, chronic disability that meets all of the following four conditions: is attributable to cerebral palsy, epilepsy, autism, Prader-Willi syndrome, or any other condition found to be closely related to developmental disability, because the condition results in impairment of general intellectual functioning or adaptive behavior similar to that of people with developmental disabilities, and requires treatment or services similar to those required for people with developmental disabilities. This does not include mental illness as defined under Minnesota Statute 245.462 Subdivision 20. This also does not include emotional disturbance as defined under Minnesota Statute 245.4871 Subdivision 15. 2 is manifested before the person reaches 22 years of age. 3 is likely to continue indefinitely, and 4 results in substantial functional limitations in 3 or more of the following areas of major life activity: self-care, understanding and use of language, learning, mobility, self-direction, or capacity for independent living. Substantial functional limitations means the long-term inability to significantly perform an activity or task. For more information, review Minnesota Rule 9525.0016. Background and helpful context for following the rule. In the definition section of the rule, qualified professional refers to a specific assessment approved by the commissioner that certain professionals are required to complete. This can be found in TrainLink titled Positive Supports Rule, MN Rule 9544, or PSR 100. A Positive Support Transition Plan, PSTP, DHS 6810, PDF, is referenced several times in the rule. It is a template for teams to outline their plan to teach a person new skills and to develop support strategies to prevent challenging behaviors. A PSTP is required for 245A licensed providers only if there are 3 incidents of emergency use of manual restraint, EUMR, within 90 days, or 4 incidents within 180 days. If a 245A licensed provider also uses procedures prohibited under Minnesota Rule 9544.0060, like mechanical restraint or seclusion, for example, there must also be included in the PSTP as targeted interventions, even if these procedures are allowed under other statutes, such as in secure facilities. When a PSTP is created for an individual and the incidence of targeted interventions listed in the plan do not decrease within 6 months, service providers must submit a request to the case manager or directly request help with the PSTP from an external qualified professional. For example, if there are 2 incidents of EUMR in January, 2 in February, and then 5 in June, this increase in restraint use would require consulting an external qualified professional. Working with other professionals, such as occupational therapists, speech-language pathologists, or behavior analysts, is common and encouraged when supporting people with challenging behaviors. Functional behavior assessments. A functional behavior assessment, or FBA, is the process of closely examining why behaviors occur. An FBA is required anytime a PSTP is created or when a qualified professional develops or modifies a written intervention to change a target behavior. Conducting this type of assessment can help teams develop effective positive support strategies that address the root causes of a behavior. For example, a team might need to conduct an FBA after a child engages in a target behavior, such as stealing food items at a store. If the reason is hunger, a positive support strategy could be teaching the child to ask for or bring snacks along when out in the community. If the reason is fear of going without food due to past trauma, a strategy could be teaching the child to safely store food in their room as a backup outside regular meals. If the reason is to get attention, a strategy could be teaching the child to ask for attention or providing more frequent attention. Or if the reason is to share with others at school to stop bullying, the strategy could involve working with the school to address bullying and teaching the child other ways to connect with the other children. Who can conduct an FBA? The license holder's qualified professional or an external qualified professional must conduct the FBA. The license holder must verify and document that the professional meets the applicable qualification requirements in Minnesota Rule 9544.0020, Subpart 17 or 47. Required elements. At a minimum, an FBA must include direct observation of the person, Evaluate whether the following factors make the target behavior more or less likely to occur. Biological factors, identified through medical or dental assessments, like pain, dizziness, seizures, or limited range of motion. Psychological factors, identified through a diagnostic or suicidality assessment, like depression or seeing things that are not there. Environmental factors, identified through direct observation or talking with a significant individual in the person's life, like confrontation with others, lack of appropriate clothing for the weather, or lack of adequate space. And quality of life factors, like not having enough money to do the things they want or struggling to reach a goal, etc. After assessing these factors, the professional must generate a hypothesis or statement about why the behavior occurs. If unsure about meeting the requirements, they can use the optional Functional Behavior Assessment Quality Checklist, DHS 6810F PDF, to evaluate the quality of their work. Sometimes the FBA process is relatively simple, and the team can easily identify the cause of the behavior and how to address it. Other times it can be complex and might require extensive data collection, appointments with specialists, and trial and error. It is normal for multiple professionals to work together on assessments, so don't hesitate to ask for help if you are not sure about a portion of the assessment. Positive support strategies. A positive support strategy means a strengths-based strategy based on an individualized assessment, such as an FBA or other type of assessment, that emphasizes teaching a person productive, self-determined skills or alternative behaviors without the use of restrictive interventions. Service providers must use positive support strategies when delivering services. At least every 6 months, in collaboration with the person, the license holder must assess the person's strengths, needs, and preferences, select positive support strategies that integrate the person into their community and are evidence-based, person-centered, ethical, the least restrictive option, and effective, support the person's self-determination and decision-making, create a desirable quality of life for the person through inclusive, supportive, and therapeutic environments, and evaluate the effectiveness of these strategies, usually by collecting data in various forms. Based on this review, the license holder should decide if the strategies need changes and make any necessary adjustments. Remember that staff implementing positive support strategies are more likely to succeed if their own basic needs, like housing, food, and safety, are met. Regularly check in with employees and colleagues to see what they need to effectively meet these requirements. Examples of positive support strategies. Example 1. A person receiving supports who does not use words to communicate engages in self-injurious behaviors when their service provider does not do something as expected. The service provider works with the person to conduct an assessment and develops a plan for improving communication by teaching them how to use a new picture system, which is a positive support strategy. If needed, they may ask the lead agency to bring in specialists, such as a speech-language pathologist, to help the person and their team. The team starts by collecting data on how often the person engages in self-injurious behavior and continues to track this over time to see if the frequency changes with the use of the new picture system. In this example, if the frequency of self-injurious behavior decreases, it might indicate that the new picture system for communication is effective. However, other factors could also influence this change, such as the person's health or how staff are responding to the self-injury. However, if the team finds that the frequency of self-injurious behavior increases or stays the same, they may need to modify the positive support strategy, replace it with a different strategy, add more strategies if the person's communication skills have improved but self-injury hasn't decreased, or ensure caregivers implement the strategy more consistently. Example 2. A teenager receiving support causes significant property destruction when unsure how to answer schoolwork questions. The service provider works with the person to assess the situation and develops a support plan that includes teaching coping skills and a reward system for using those skills instead of destroying property. The team has data showing that the teenager engaged in property destruction 7 times during school lessons over the past week. They continue to track data over the next couple of months to see if property destruction decreases with the new support plan, and also start collecting data on the use of coping skills. In this example, either a decrease in property destruction or an increase in the use of coping skills could indicate that the plan is effective, although other factors outside the plan may also affect the teenager's behavior. If the data shows that the support plan isn't working, the team should revise the plan and consult other professionals as needed to improve supports. Example 3. A person is in a loud environment and starts feeling overstimulated, but they are unable to leave the area due to program rules. They begin damaging property, yelling, and trying to get others to join in. The service provider talks with them privately to find out why they are upset. Although the person doesn't say they're overstimulated, their pacing and comments about how annoying and stupid everything is suggest they might be. The provider then helps the person go to a quieter area where they have more space to relax, and explains that they can ask staff for a quiet space when they need a break. The provider later updates their program policies to allow all residents access to quiet areas when desired. Going forward, the program encourages the person to ask for quiet time when needed and positively reinforces this choice when they do so. Professional standards for positive support strategies. The license holder must use professional standards for positive support strategies, which can be found through the following resources: the Association for Positive Behavior Support Standards of Practice, the United States Department of Health and Human Services, Substance Abuse and Mental Health Services Administration, SAMHSA, National Registry of Evidence-Based Programs and Practices, SAMHSA Roadmap to Seclusion and Restraint-Free Mental Health Services, the Behavior Analyst Certification Board Guidelines for Responsible Conduct for Behavior Analysts, the NADD Competency-Based Clinical Certification Program, Competency Standard 3, Positive Behavior Support and Effective Environments, and other standards approved by the Commissioner that have been peer-reviewed, are widely accepted as authoritative, and reflect current best practices. Documentation requirements. The person's positive support strategies must be written into their service plans, and service providers must document the progress or lack of progress toward each outcome or goal for each person, including progress made on quality of life indicators. The service provider must also keep data to ensure staff are accountable for the services provided, and allow the service provider and DHS to evaluate and monitor services. However, service providers offering family childcare, family foster care, or family adult day services are not required to document general positive support strategy activities for children and adults who do not need a PSTP, though doing so might be helpful in providing effective services. Person-centered planning. For people covered by Rule 9544, the service provider must use person-centered planning. This planning must, to the extent desired by the person, include life planning, put the person at the center of the planning process, identify goals, build on the person's capacity to engage in activities, and promote community involvement and close personal relationships. At least every 6 months, the license holder must evaluate with the person whether the services support the person's individual preferences, daily needs, and activities. The services help the person achieve their goals. The person-centered planning process complies with Code of Federal Regulations, Title 42, Section 441.725, Paragraph A 1 through 4, which requires that the process includes people chosen by the individual, provides information and support so the individual can lead the process as much as possible, helps the person make informed choices and decisions, is timely and takes place at convenient times and locations to the individual, reflects cultural considerations of the individual, provides information in plain language, and is accessible to individuals with disabilities and those with limited English proficiency. Based upon the results of the evaluation, the license holder must determine whether changes are needed to enhance person-centeredness for the person, and if so, make appropriate changes. Resources for person-centered practices. DHS created the Person-Centered Practices webpage to provide additional information on this topic. Supporting the mental health needs of people who use psychotropic medications can be challenging for many caregivers. To help with this, DHS created a psychotropic medication manual to assist service providers in using person-centered practices with these medications. In partnership with DHS, the University of Minnesota offers a variety of resources on their Positive Supports Minnesota Person-Centered Practices webpage. Permitted procedures. When written into the person's service plan and approved by the expanded support team, and by parents in the case of a child, the following procedures are allowed. Positive verbal correction that is focused specifically on the behavior being addressed, and temporarily taking away or removing items that are being used to harm the person or others. The following examples of physical contact or techniques can be used, but only if they are the least restrictive way to meet the person's needs. They can be used occasionally or continuously, but if used continuously, they must be documented in the person's support plan addendum. These include holding someone to calm or comfort them if they do not resist, protecting someone who frequently falls due to a medical condition, helping the person complete a task or respond as long as they show no or only minimal resistance, blocking or redirecting a person's movements without holding them or limiting their movement to interrupt the person's behavior that may result in injury to self or others with less than 60 seconds of physical contact by staff, and redirecting a person's behavior when the behavior does not pose a serious threat to the person or others, and the behavior is effectively redirected with less than 60 seconds of physical contact by staff. Restraint may be used for the following situations: allowing a licensed health professional to safely perform a medical exam or treatment ordered by a licensed healthcare professional, assisting with safe evacuation or redirection in an emergency if there is an imminent risk of harm, or positioning a person with physical disabilities as specified in their support plan addendum. Any use of allowable manual restraint must not restrict normal access to a nutritious diet, water, ventilation, medical care, hygiene facilities, sleeping conditions, clothing, or any required state or federal standards, deny visitation or contact with legal counsel, a legal representative, or family, be used for staff convenience, punishment, as a substitute for adequate staffing, or as a consequence if the person refuses to participate in treatment or services provided by the program. Use prone restraint, which means use of manual restraint that places a person in a face-down position. Prone restraint does not include brief physical holding of a person who, during an emergency use of manual restraint, rolls into a prone position if the person is restored to a standing, sitting, or side-lying position as quickly as possible, or be used in a way that is contraindicated for any of the person's known medical or psychological limitations. Prohibitions. The procedures in this section are prohibited when used in any of the following ways: as a substitute for adequate staffing, for staff convenience, for a behavioral or therapeutic program to reduce or eliminate behavior, or as punishment. Whether a procedure is prohibited depends on why it's being used. For example, using a helmet to prevent head-banging behavior is not allowed, but it may be permitted to protect someone who has seizures they can't control. However, these prohibitions may vary depending on other statute requirements, such as allowances to use handcuffs in secure correctional facilities. When following regulations, remember that new statutes can sometimes override existing rules. This training is based on current rules as of January 2025, but if a new statute is passed that conflicts with any rule mentioned here, the new statute would generally take priority. Prohibited procedures include using prone restraint, metal handcuffs, or leg hobbles, using ferretic shock, speaking to someone in a way that ridicules, demeans, threatens, or abuses them, using physical intimidation or a show of force, containing, restricting, isolating, secluding, or otherwise removing a person from normal activities when it is medically contraindicated or without monitoring the person, denying or restricting a person's access to equipment like walkers, wheelchairs, hearing aids, and communication boards unless temporarily necessary to prevent injury to the person or others or serious damage to the equipment, The equipment must be returned to the person as soon as imminent risk of injury or serious damage has passed. Using painful techniques or intentionally causing pain, fear of pain or injury, dehumanization or degradation, hyperextending or twisting body parts, tripping or pushing someone, using punishment of any kind, forcing a person to hold a specific position or posture, using forced exercise, restricting a person's senses, presenting intense sounds, lights, or other sensory inputs, using toxic or gross smells, tastes, substances, or sprays like water mist, denying or limiting access to normal goods or services, or making people earn these basic needs, using token reinforcement or level programs that include a response cost or negative punishments, making a person discipline another person receiving services, using actions that are medically or psychologically contraindicated, using techniques that could obstruct breathing or put pressure on the head, neck, back, chest, abdomen, or joints, interfering with a person's legal rights as defined by federal regulation or state licensing standards governing the program, using mechanical restraint, using chemical restraint, using manual restraint except in emergencies, or using any other interventions or procedures that may constitute an aversive or deprivation procedure. Definitions of these procedures can be found under Minnesota Rule 9544.0020. Token programs. If you are using a token reinforcement or level program, make sure it doesn't include any kind of penalty or negative consequence. For example, it's okay to give rewards when someone reaches a goal. Token programs are common in everyday life, like getting a good grade for hard work or a paycheck for working. However, under Minnesota Rule 9544, you can't take away a reward that someone has already earned just because they don't meet a new goal or engages in an undesirable behavior. It is important to note that service recipients should have access to basic goods and activities like phone calls, spending time with friends, snacks, movies, sports, or video games without having to earn them. This doesn't mean all rewards need to be offered all the time. For example, while it's common to eat out occasionally, most people don't eat out every day. So paying for someone's meal could be an occasional reward, but they shouldn't have to earn every opportunity to eat out. Key points to remember. 1. Basic needs like food, water, medicine, and shelter must never be withheld. 2. Poorly designed token programs can lead to distrust or unwanted behaviors. And 3. The most effective token programs are respectful, age-appropriate, and individualized to each person. If you're unsure if your token program meets these requirements, you can email Positive Supports at state.mn.us for guidance. Requirements for emergency use of manual restraint, EUMR. Emergency use of manual restraint, EUMR, means using a manual restraint when a person poses an imminent risk of physical harm to self or others. EUMR must meet the following conditions. It must be necessary to protect the person or others from imminent risk of physical harm. The restraint used must be the least restrictive way to eliminate the risk and make the situation safe. The restraint must stop as soon as the risk of harm is over, and the service provider must monitor the person's health and well-being during the restraint. Staff monitoring the procedure must not be the staff implementing the procedure when possible. Property damage, verbal aggression, or a person's refusal to receive or participate in treatment or programming on their own does not constitute an emergency. However, some situations might rise to the level of being considered an emergency, such as a property destruction that involves breaking glass in a way that the person is likely to be cut by the glass, when a PSTP is required for EUMR. As mentioned earlier in this training, service providers must develop a PSTP for a person who has been subjected to 3 incidents of EUMR within 90 days or 4 incidents of EUMR within 180 days. Reporting the use of EUMR. Each licensed program has specific reporting requirements. For example, in children's residential facilities, Minnesota Rule 2960.0710 Subpart 6G requires that a mental health professional or program director be contacted within 30 minutes of starting a physical hold or seclusion, and Subpart 6K identifies what needs to be documented. The next section of this training will review the form that must be submitted to DHS when an EUMR or other reportable intervention is used. Use of EUMR to ensure safety. Service providers should keep in mind that EUMR is only allowed in limited situations. For example, if a person is cutting their wrists or runs in front of traffic, service providers might need to physically intervene to save the person from harm. Failure to protect the person could potentially be considered neglect. Sometimes service providers might call 911 instead of using EUMR, but calling emergency services is not always an option. Emergency responders may not arrive fast enough to help, or the person might be afraid of them, which could make the situation worse. It is important for providers to find a balance between avoiding restraint and ensuring people are kept safe from harm. Required notice. When services start, or whenever the provider creates or changes their policy on EUMR, they must inform the person receiving services about this policy. This notice must clearly explain the person's rights and be in writing, and the provider must get a signed acknowledgement from the person, or their legal representative if applicable, confirming they were informed. Requirements for reporting the use of restrictive interventions and incidents. Service providers must use the Behavior Intervention Reporting Form, BIRF, which can be found on the DHS Reporting Restraint Use, Behavior Interventions and Other Incidents webpage, to report the following incidents to the Commissioner for people covered by this rule: an emergency use of manual restraint, a medical emergency occurring as a result of the use of a restrictive intervention with a person that leads to a call to 911 or seeking physician treatment or hospitalization for a person, a behavioral incident that results in a call to 911, a mental health crisis occurring as a result of the use of a restrictive intervention that leads to a call to 911, or a provider of mental health crisis services as defined in Minnesota Statute 245.462 Subdivision 14C, an incident that requires a call to mental health mobile crisis intervention services, a person's use of crisis respite services due to use of a restrictive intervention, use of Pro-Renata PRN medication to intervene in a behavioral situation. This does not include the use of a psychotropic medication prescribed to treat a medical symptom or a symptom of a mental illness or to treat a child with severe emotional disturbance. An incident that the person's Positive Support Transition Plan, PSTP, requires the program to report, or use of a restrictive intervention as part of a PSTP as required in the plan. For examples of inappropriate PRN use that require a BIRF and suggested actions to handle these situations, see the PRN medications and chemical restraint sections on the DHS Psychotropic Medication Manual, Preparing for Appointments webpage. Reporting timelines. The timelines for submitting a report to DHS can be found in the Positive Support Transition Plan Instructions, DHS 6810B, Part 6. Resources for staff training requirements.
Service providers must ensure that staff responsible to develop, implement, monitor, supervise, or evaluate positive support strategies, a PSTP, or the emergency use of manual restraint complete initial and annual training requirements.
A list of the core training requirements can be found in Minnesota Rule 9544.0090. Service providers can access free or low-cost trainings for their staff to meet these requirements through the College of Direct Support. The University of Minnesota provides an outline of which courses meet the rule requirements. To view the outline of which courses to take, visit the Using the College of Direct Support to Meet the Minnesota Positive Support Rule Training Requirements webpage. Quality Assurance and Program Improvement Requirements. Service providers must have a program improvement process to regularly evaluate how well positive support strategies and person-centered planning are being implemented and to find strengths and areas for improvement. Providers must carry out this review at least every 6 months. After reviewing, the license holder must take steps to address any issues found. They must also keep records of these improvement activities and provide data on the process and outcomes when DHS requests it. Introduction to the External Program Review Committee. The External Program Review Committee, or EPRC, monitors the implementation of Minnesota Rule 9544, recommends policy changes to the Commissioner, reviews requests for the emergency use of procedures and makes recommendations to the Commissioner to approve or deny those requests, and reviews reports of the emergency use of manual restraint and provides guidance to license holders. The committee works closely with a DHS team that manages projects and activities related to Minnesota Rule 9544. After submitting a Behavior Intervention Reporting Form, BIRF, or Positive Support Transition Plan, PSTP, service providers may receive an email or call from an EPRC or DHS representative. Both groups aim to provide helpful and friendly support to assist service providers in following the rule. Service providers can reach these groups by emailing positivesupports@state.mn.us. Be sure to mention that you are licensed under Minnesota Statute 245A, not 245D, as the requirements are slightly different. You are also welcome to attend the EPRC's monthly public meetings to give feedback on policy requirements.
Overview of the variance process.
Minnesota Statute 245A.04 Subdivision 9 allows the DHS Commissioner to grant variances for rules that do not affect the health or safety of people in a licensed program under certain conditions. However, DHS will not grant a variance to allow the use of a prohibited procedure as defined in the rule, which is different from the request for the authorization of the emergency use of procedures process. Other variance requests will be reviewed individually, following DHS guidelines and legal authority. To request a variance, use the DHS Variance Request Form, DHS 3141 PDF. Conclusion. Thank you for taking time to learn about positive support strategies and person-centered practices under Minnesota Rule 9544. For more information, visit the DHS Positive Supports webpage. If you have questions or comments about the rule or this training video, please send an email to positivesupports@state.mn.us. You can also contact your licensor with questions. If you are unsure how to contact your licensor, visit the DHS License Programs webpage to find contact information by license type.